Next, I call upon Dr. Jayashree. Dr. Jayashree PV will talk on mistakes in gonioscopy.
So, good afternoon. At the outset, I would like to thank Dr. Mallika and Dr. Smita and KSOS for the opportunity. So, I'll be dealing on the mistakes in gonioscopy. As we all know, gonioscopy is a technique used for viewing the anterior chamber angle, and it was initially trained as in 1907 who viewed the angle of the anterior chamber. It was not with a gonioscope. It was in a keratoglobus eye. Why are we not able to see the angle without the help of a gonioscope? That is because of total internal reflection. The light coming from the angle reflects from the tear air interface and goes back into the eye. And that is why we need a contact lens for viewing the angle. It can be a direct contact lens or a indirect prism or mirror. So, whom all we should do a gonioscopy. So, ideally, all the patients who come to your OPD should undergo a gonioscopic examination, but that is not practically possible. So, at least whom all should we do gonioscopic examination? It's like 1 Herix positive patients. In all the patients whom we suspect glaucoma, who are already developing glaucoma patients who all are under risk for secondary glaucoma, those patients in whom we are planning for angle procedures, or those who patients underwent glaucoma procedures, those patients need gonioscopic examination. So mistake number 1 would be not doing gonioscopy. Say, gonioscopy need to be being a contact procedure, we need to avoid in certain conditions, and also immediately post blunt trauma, because of a risk for the hyphema. Immediately post trauma we can avoid gonioscopy for some time, but it is very important that after a few days we have to do gonioscopic examination, because we have to rule out angle recession and cyclodialysis cleft, etc. So that is very important for a future glaucoma, like angle recession glaucoma and hypotony in cyclodialysis cleft. What are the commonly used lenses? It will be, in a clinic, it will be indirect lens, like a 4-mirror lens or a Goldman 3 or 1 mirror lens. Which of them is ideal to be used? Ideally, it is a 4-mirror lens that needs to be used. The main advantage of using a 4-mirror lens is that it enables us to do what is called indentation gonioscopy. What is indentation gonioscopy? You apply pressure on the cornea so that you can differentiate what is between appositional closure and synovial closure. Appositional closure is when you press on the cornea, the angle opens up. Synovial closure, this closed angle does not open up. There is a permanent PAS. Why are we able to do this apposition indentation gonioscopy? The inner diameter of the gonioscope is smaller than the corneal diameter. So it presses the aqueous onto the angle and angle opens up. So that is not possible with the other type of contact gonioscope. The disadvantages, it is little difficult initially, and inadvertently you might apply pressure. So inaccurate selection of gonio lens is a second mistake. So where do you use the direct lens? It is for surgical gonioscopy. The major disadvantage is patient has to be in supine position. Well, how do you do the procedure? You have to put a topical anesthetic drop, position the patient at the slit lamp. Patient has to look at the primary position. Elbow needs to be supported. Otherwise, you might inadvertently press onto the cornea. And the room light has to be dim. Otherwise, it can open up the angles. Hand position. You hold the gonioscope with 3 fingers. The 2 of the fingers rests on the patient's cheek. So further pressure is not applied to the patient's eye. The other hand is free to use the slit lamp. The coupling agent is not required here, and lens is applied with very much, with just a touch and interpalpable area only, without touching the lashes as long as possible. And initially, you have to use the lowest illumination, the lowest height of the beam that is possible. And when we transit and look at the 4 angles, you can simultaneously look at the 4 angles. You don't have to rotate the gonio lens. So when you are transiting, don't go through the pupil, go through the sides so that you don't accidentally open up the angles. And after that, you can use a brighter illumination to see the details in the angle. So mistake number 3 here is you are inadvertently opening the angles because of a higher illumination. So these are the angle structures. Schwalbe's line, trabecular meshwork, the anterior non-pigmented, posterior pigmented, scleral spur, and the ciliary body band. Corneal wedge is the thinnest beam and the brightest illumination. The anterior posterior corneal surfaces meet at the Schwalbe's line. And why is this important? Because in a open or closed angle, it is more important because very lightly pigmented open angles might appear as a closed angle because you are not able to identify a trabecular meshwork and you think it is an closed angle. Very pigmented angles, even the Schwalbe's line is so pigmented that you might mistake it for a trabecular meshwork. And so identifying the anatomical landmarks is, just a minute. Yeah, missing the anatomical landmarks is the fourth mistake that you can do. Another one, indentation gonioscopy. You can see this is the Schwalbe's line. When I do the indentation, another line comes behind that. Can you see that? That is the trabecular meshwork. Initially, Schwalbe's line is seen and indentation leads to trabecular meshwork. You can see that I am doing indentation because that DM folds are seen on the gonioscopy. So this is the Schwalbe's line that which is pigmented, and that is the not doing indentation gonioscopy is the next mistake. Again here. Orientation. It is reversed but not laterally rotated. So what is at 1 o'clock will be at 5 o'clock, 12 o'clock, 6 o'clock. So the PI here is going to be here and not here. That has to be remembered. So confusing with the orientation is the next mistake. There are n number of classification systems. Usually used one is Schaeffer system. The grade 4 is open in Schaeffer's. Schiess system, it is closed. And Spaeth describes the angles. So if you mention it is grade 4, it doesn't mean anything. You have to mention the system and then only mention the grade. So not mentioning the system of classification then it doesn't help. The other mistakes are not repeating the gonioscopy periodically. So once you do the gonioscopy, it's not like one-time procedure. You have to periodically repeat it, not documenting properly, and not following the order of examination. Order of examination, by that what I mean is, if you do gonioscopy first, it can reduce the IOP by 1 to 2 millimeter. So initially do the GAT and then do the gonioscopy. That is the order of examination. And you have to do both the eyes. So gonioscopy is still the gold standard. Inter-observer variability is the most difficulty in that. Practice makes you perfect. Thank you.
Thank you, Dr. Jayashree. That was a very good presentation, really excellent. And I very much liked your comment, not doing gonioscopy is a first mistake. That's a very good comment. Excellent presentation.